All right, well, thanks very much. Thank you, Axel, and congratulations on your program again this year. It couldn't be any more honor than debating my dear colleague, Dr. Bikai Saab. You guys should plan. You don't put two Lebanese to debate each other because they open a political party by the end. But anyway, we'll see what we do there. So my job is to really prove to you that there is actually a standard second-line therapy for HCC, which is Regorafenib is a winner. If anything, let's see this. Use mouse as pointer. So these are my disclosures, and this is how you can reach me. We're tweeting, by the way, already about the debate.
You're
so
tweeting?
That. Yeah,
oh,
absolutely.
Okay.
Yeah, you're not following me?
Oh.
All right. So anyway, the phase 3 trial, SHARP trial, you are all familiar with, was really what started this whole field of HCC, if you want to say. Patients with advanced HCC, Child-Pugh-A, randomized to Sorafenib, a multikinase inhibitor with anti-angiogenic effect versus placebo, with the primary endpoint being overall survival. If you recall, the data came positive, 10.7 months for the Sorafenib versus 7.9 for the placebo, clinically and statistically significant. If anything, this led to the approval of Sorafenib as being the standard of care that we all use in regard to advanced HCC. So the Sorafenib, other than establishing a standard of care, it helped many other aspects of the disease. Number one is there was a reference that now we're talking about, which is like, when we come to do clinical trials, we know what to compare to. But probably more importantly, and especially for our patients, it opened really the door in regard to multiple clinical trials that came forward, trying to see, of course, if we can pass the needle beyond Sorafenib, and this is especially in the first-line setting. I would say the subject of the first line was rather a pretty narrow focus and mainly directed towards anti-angiogenic therapy. And as you can see over here, every anti-angiogenic that has been known was tested in HCC at the cost of about like 4,000 patients or so in all those trials. And unfortunately, there was not a single bit from the 10.7 month of the Sorafenib as a single agent. That's what led Alan Vinook and I to talk about the anti-angiogenic ceiling that we published in Lancet Oncology at that time, arguing that there could be other aspects to the disease that need to be debated beside the anti-angiogenic effect of Sorafenib. Interestingly, and within almost 10 years, remember now we're 2017, the whole Sorafenib story only started in 2007, so within 10 years or only 1 decade, there was already talk about second-line therapy. And I have to say that the second-line approach has been rather more varied. If anything, it's different targets. You can see on top of the list Sorafenib as a anti-FGF, everolimus, anti-mTOR inhibitor, ramucirumab, another anti-angiogenic, ADAPEC-20, imetabolomic for arginine depletion, and c-MET inhibitors, Regorafenib, which we'll talk about quite a bit today about, and of course there was a ramucirumab redo with a alpha-fitrini more than 400. Now, as you noticed in the 4 phase 3 trials that are reported on top, unfortunately none of them were positive, despite really there was quite a bit of good scientific argument for the drugs to be tested in that regard. But it appears to be that one of the soft arguments given all along is that the placebo arm did better than we thought it might. And yes, maybe true. And why is that? Because simply by the time we are evolving in the understanding and management of the disease, we are all acquiring better knowledge, better referral patterns, earlier referrals, and probably altogether we were able to really influence the outcome even on the placebo just because of the multidisciplinary approach that now we're better at. On the other hand, there is a clear reality over here that the drugs did not necessarily work. Actually, you could look at subgroup analyses, some different aspects of the drugs that would argue that they could have worked if and why, but at the end of the day, they were negative trials. The Regorafenib came along with positive data, which we'll talk about. But interestingly, before we get there, if you kind of take yourself back in time to about 2010 or so, the hottest subject at that time on HCC was actually c-MET inhibitors. Everybody was trying to get a c-MET inhibitor. Tivantinib, interestingly, showed very valuable data in the second-line setting in a phase 2 trial, which was randomized versus placebo. If anything, there was doubling survival among c-MET positive patients. In other words, they had to have 50% expression of 3 to 4 plus to really get to the improvement in survival. That led to a phase 3 trial of tivantinib versus placebo in this very specific population, which unfortunately unfortunately, however, as a press release was just sent a few weeks ago, did not meet its primary endpoint. We don't know the data yet, but that's definitely a quite concerning outcome in regard to the c-Met inhibitors. And phase 3 cabozantinib versus placebo, again in the second-line setting, but this time allowing all patients, all comers, not necessarily only c-Met high patients to be accrued. We're waiting to see how this might pan out. So that's really the c-Met story kind of evolving, and everybody's about it. And then out of nothing, from the left field, without anybody's expectation, the Regorafenib data came out. A study that really went on rather quietly but effectively and accrued in a reasonable time. Patients with HCC received Sorafenib, progressed on Sorafenib. These are very important definitions. So they did receive Sorafenib and they did actually progress on Sorafenib, and then they were allowed to go either on Regorafenib versus placebo by random, with the, of course, overall survival as a primary endpoint. So over here you can see that there was actually a true effective outcome improvement. Regorafenib 10.6 months and placebo 7.8. For Tony, as you know, Dr. Meyer told us that whenever you can stick 3 fingers between the curve, it's positive. So this is really positive. Actually, you can't put more than 3 here, but anyway. So this is really positive data that obviously kept us a little bit kind of unsure, like how come, where is this coming from? Because there wasn't a certain understanding that Sorafenib and Regorafenib are probably cousins after all, and like how would you give a drug that already patients progressed on, and now you give a close cousin off, and it appears to be that they respond again. So actually, it is probably true that Regorafenib is a cousin of Sorafenib, but probably a distant one. It's not necessarily that this fluor is kind of enough to really make a difference per se. If anything, it appears to be, that the combination, one after the other, not only is dependent on a multikinase activity per se, but it appears to be that there's some data that is not published yet that looks into the IGF and FGF activity that maybe rises after Sorafenib is given, and as such probably give a leeway for the Regorafenib to be able to exert its effect. So there is a clear science over here that probably will argue in that regard. And interestingly, not only that, if you really were to combine the Sorafenib plus Regorafenib, it appears to be that the data that was published, or reported rather, in person by Jordi Bruges at ILCA in Vancouver last September, spoke about 26 months in median survival for the combination. This is after analyzing data. How this can happen? It appears to be that in comparison, this is definitely a very solid sign, because this is data from our group in regard to TACE in BCLC-B, and as you can see, we published that in JCO back in 2016. The best median survival in regard to TACE is 20 months. So how come you can even do better in BCLC-C patients with systemic therapy, with a sequence of therapy and a plan of therapy that really will include the Sorafenib followed by Rego, that even bypass what you can do as a median survival in regard to local therapy? So definitely that's a signal not to ignore per se. And if anything, not only the argument is in regard to the survival, but also there are responses, and there is a doubling in regard to the progression-free survival based on the modified RECIST. Of note, by the way, this is the first modified RECIST study that was done prospectively. In other words, really they planned modified RECIST right from the beginning, so something to give them credit for in that regard as well. And very important facts for the non-believers is that number one is you can argue and say, well, patients were on Regorafenib only after they were on Sorafenib only for a very short period of time. Maybe like they got it and they just moved on from it very quickly. Well, it appears to be it's not true. If anything, the time on the median time on the Sorafenib was about 7.8 months in both arms. So patients really got a good shot at Sorafenib for a reasonable period of time before they progressed. Number two, an argument said that maybe they did not really stay too long in between the two therapies. It appears to be that the median time from progression was only about 1.4 months. At the same time, the time of discontinuation of therapy to start the new therapy was only 0.9 months, or 28 days to be very specific, i.e. there was no selectivity for those patients to get onto the Regorafenib after the Sorafenib by being off therapy for a long period of time. So this is definitely, again, argue in favor of the Regorafenib as being a potentially new standard of care in the second-line setting. And as you can see over here from the forest plot, which already is published in the Lancet, which is a high-tier journal, just to remind you, so, that actually across the board in all the subgroups, it appears to be that there was a positive effect and improvement in outcome for the patient who received regorafenib, as you can see over here. So, if anything, before I pass on Dr. Bikai Saab to give you the alternative facts, I will conclude here that regorafenib improves survival in second-line setting patients who progress on first-line therapy sorafenib. The biology is compelling and may well explain for the improved of TKI approach, which what kind of, hopefully we'll see more data of. And if anything, the Sorego approach poses a question regarding local palliative therapy too, because of what I brought up in regard to the 26-month median survival. No doubt we might hear from our opponent about checkpoint inhibitors, but remember one thing, the name of the game is called overall survival. Until then, I think we can't talk except about data that has shown improvement in survival. So I'll take the microphone and I'll drop it and I'll wait for Dr. Saab.